Good morning. Thanks, Jack and Artie, for inviting me to give this talk. How many of you guys treat children? Raise your hands. And if you're online, you can type in children. I have the chat up here. Okay. How many of you guys take care of adults who have a history of a pediatric rheumatic disease like JIA? Okay, the most of you. All right. So hopefully this talk will be very relevant to all of you. So I'm a pediatric and adult rheumatologist. So I spend about half my time at Children's Hospital evaluating children, and then the other half at the Beth Israel treating adults. And what I'm hoping to teach you guys today is a little bit about getting a better perspective of what JIA is, because that term is thrown around and it's sometimes difficult to understand as an adult rheumatologist, and then help you improve the transition of care between pediatric rheumatology to when they see you in your adult rheumatology clinics. And we'll be able to do this by a case that I have of a patient that I've been following over the last few years. These are my disclosures, hopefully nothing relevant to today's talk. So I'll try to get you to enhance the transition process. I'll explain my 5 steps for successful transition, talk a little bit more about distinguishing the various subtypes of JIA, compare them with adult arthritis, and thinking about what it is that you have to remember about these patients who, by the time that they see you, may have had disease for 10 or 20 years. So my patient is a 24-year-old young woman. She was diagnosed with JIA at age 4 and was referred to me as an adult rheumatologist to take over her care at age 24. Most of the patients that I see that are transitioning, I actually take them, from Boston Children's, and I tell them, hey, next time I see you, I want to see you across the street at the BI. But this is one of those patients that you may see that they came from a different pediatric rheumatologist and so had no ties to me before seeing me. So the most important part of transitioning patients from pediatric to adult rheumatologist is to actually make the transition. And that sounds easy, but in fact it's not so easy. 52%, that's the number of pediatric patients who are referred to adult rheumatologists who actually never make it there after 2 years. So it's a huge problem, and we know that this comes at a time in life when young adults are particularly vulnerable. So the most important thing is to actually get the patient to see you in adult rheumatology. So how can that be improved? Well, the transition between pediatric and adult rheumatology requires what we call, self-management skills. So the ability of patients to sort of know what their disease is, know what medications they're taking, be able to call the pharmacy and get refills, deal with insurance companies. And these are skills that do not come naturally to young adults. Actually, they don't come naturally to anybody. Fortunately, studies have shown that these are skills that can be learned, and that by learning these skills, clinical care improves and costs of medical care actually decrease. So it's very powerful. And you might be thinking, well, where do I belong in getting the patients ready? And certainly a lot of what needs to happen for the transition process to be successful actually needs to take place at the pediatric rheumatologist's office. Transition of care is actually a long process. As you see here, it starts, as soon as the patients become teenagers, sort of around age 12 is ideally when the pediatric rheumatologist is sort of getting their patients ready to transition to adult care. So what should you be doing as an adult rheumatologist? So this website, it's gottransition.org, has great information about enhancing the transition process, both from the pediatric perspective and the adult perspective. This is what you should be doing as an adult rheumatologist in your practice. You know, the first thing is having a transition guide. So speaking with your staff about who's going to be seeing these patients, having guidelines about how medical care and transition of care should actually take place, being able to track and monitor the patients that are referred to you, orientating your patients to your adult practice, giving them a sense of, you know, what it takes to be an adult patient. You have to realize that for most of your patient's life, their care has been managed by their parent, right? So, you know, remembering to get blood work, remembering to get refills, scheduling their visits, everything has been taken care of by their by their parent. And the pediatric rheumatologist's office is made to support those patients. So the nurses, you know, actually call the patients like, hey, you haven't gotten your blood work. Or the nurses are there to help them out in getting their refills. And these are things that generally don't happen in our adult practices. So getting your clinic office ready for these patients, and then getting your patients ready and to realize what are the expectations of being an adult patient. These are the things that need to happen. And of course, having a good relationship with your local pediatric rheumatologists so that you know, get all the information you need to be able to take care of these patients. And you know, these transition programs have actually been shown to improve quality of life, patient autonomy, independence. They improve the success of establishing care in an adult rheumatologist. You know, other studies have shown that they decrease hospitalizations and improve medical care. So these transition programs are very important. So number 2 is understand their past history and JIA disease category. So for my patient, she was diagnosed at age 4. She had arthritis, fever, and rash. She was diagnosed in the early 2000s and basically experienced every medication as soon as it came out. So she was initially on NSAIDs, hydroxychloroquine, methotrexate, prednisone, and then was on a host of biologics. Her course was complicated by macrophage activation syndrome, and she was switched to canakinumab a couple of years before she transferred care to me. So the first question is, what is JIA? And this is a question that you should all be able to answer, because yesterday Pam Wise had told us what JIA was. So if you could try to get your mobile phones out and answer this question. What is JIA? Is it arthritis before 18 years of age, when manifestations have been present for 12 weeks? Is it before 16 years of age, when it's been present for 6 weeks? Is it a different type of arthritis that happens in kids, or is it just RA in little adults? Let's see how you guys are doing. All right, so the majority said arthritis before 16 years of age and manifestations persist for at least 6 weeks. And that is correct. And so what type of JIA does this patient have? Remember that she presented at age 4. She's had arthritis for 20 years. Initially, she had some fevers, rash, and arthritis. No, didn't work. There's the poll. And we'll try to make sense of all of these various categories over the next few minutes. Systemic arthritis. All right, very good. So, systemic arthritis. Yeah, so in pediatrics, it's really interesting. When I started my fellowship in pediatric rheumatology, I learned about these categories of diseases. And then when I transferred my fellowship to the adult hospital, I learned about a whole new group of diseases that were totally separate. And it's only as I progressed through my training that I sort of began seeing the similarities. As Pam Wise mentioned, if you remember from her talk yesterday, she discussed enthesitis-related arthritis and how complicated it is to get the diagnosis, because you could have enthesitis and arthritis, or enthesitis or arthritis plus other things. But if your parent has psoriasis, then that's a different category. It's really complex. And it's really silly when you think about it, because, for instance, what is the difference between oligoarthritis and polyarthritis? It's just the number of joints initially involved. So they're actually categorizing a disease mostly based on severity, as opposed to anything specific about the disease. It's like, if you had your rheumatoid arthritis patient who had 5 joints involved, you call them rheumatoid arthritis, but if 6 joints are involved, you call them multi-arthritis, right? As if they were different diseases instead of the same disease of different severity. So it's complex to diagnose them with these things. And there's another huge problem. So this is a study of 4,000 kids, Nordic children, and what happens to their diagnosis of JIA as time goes on. This was just recently published a few years ago. So these are the different types of arthritides and the number of patients that were diagnosed with these at their first clinic visit. So what happens 8 years later? See how they change categories? And what happens 10 years later? They change categories even more. So what this is telling me is that the ILAR classification is not doing a very good job of getting homogeneous groups of patients together that may help us in determine who they are and determine prognosis. If the fact that every time you see your patient, you change their JIA category diagnosis, I think it's a big problem. And fortunately, I'm not the only one that brings up the problem with this classification criteria. There's a lot of work being done with artificial intelligence about how do you make more homogeneous groups to better understand who they are. And the other question is, how do those ILAR classification categories relate to the adult arthritides? Are they the same? Are they different? Is there any connection between them? It's a big mess. And I think to simplify it, I think we should see it this way. So the rheumatoid factor positive polyarthritis patient is basically your typical seropositive RA patient. So those are easy. Then you have the spondyloarthritis. Pam Weiss spoke about enthesitis-related arthritis and psoriatic arthritis. These are your spondies presenting as children. Systemic JIA is the pediatric version of adult onset Still's disease. So that's pretty simple. And then in the middle, the seronegatives, there's actually a unique type of arthritis. This is the only one that really isn't present in adults. It usually affects like 3-year-old girls, presents with arthritis, for instance, in a single knee or in an ankle. Typically, they have a positive ANA, and they're at increased risk of developing uveitis. So that seems what it's called here early onset arthritis that is really different than the stuff that we see in adults. Everything else, is pretty much the same and has their adult correlate. So when you see a patient that is referred to you and has ERA, just think, oh, this is probably a spondy. And you guys can take care of them. So the next step is determine the extent of active disease versus chronic damage. Remember, by the time that I saw my patient, she's 24 and has had arthritis for 20 years. So does she have active disease? Does she have chronic damage? On her exam, she was afebrile. She had decreased range of motion of the wrists and ankles, but really didn't have any joint swelling that I could appreciate. And then I got some baseline x-rays. This is what your normal wrist x-rays showed, and this is hers. She has complete fusion of the carpal bones, which is pretty characteristic of systemic JIA. She also had similar findings in the ankles. So for her, she's had disease for 20 years. But, for a child who first presents with JIA, what is the likelihood that they will outgrow their disease by the time they reached adulthood? For my patient, it was 100%, because she did. But for a random patient, what do I tell my patients and their families when they get diagnosed? So most people say that they will not outgrow their disease. And then the second group is that half of them will. Interesting. And the correct answer is, it really depends. I don't know what the right answer is. I can show you some data. So this is data, the probability of remission off medications in 5 years. This is from, I think, about 1,000 patients and 1,000 children in Canada. The different colors represent the different ILAR categories, with the caveat that they're not very accurate and not very useful. But they tell an interesting picture. So this is after 5 years. Notice in the bottom, the purple is RF positive polyarthritis. 0% of patients diagnosed with RF positive polyarthritis are in remission off meds at 5 years. These are your rheumatoid arthritis patients presenting in children. I can ask you, how likely is it that your RA patient will be off meds in remission 5 years after diagnosis? Very unlikely. Conversely, the oligoarthritis in the green, those are the ones that have the highest likelihood of remission off medicines. These are, remember, the 3-year-old girls with just a single knee. Those numbers are more in the 70 to 80%. So it really depends. And then going back to that Nordic study, looking at 18-year follow-up, how many patients that were diagnosed with JIA are in remission off medications after 18 years? It's only about 40%. And those are about the rates. 40 or 50% of kids with JIA will be in remission off medications by the time they reach adulthood, meaning that you will see them in your clinic and they will likely have active arthritis. So what do you need to know about their disease? So, in addition to having active arthritis, and you guys know how to manage that, it's important to realize whether they've had any chronic damage as a result of disease for many years. And, like my patient, you may see patients with decreased range of motion of various joints, osteopenia, osteoporosis, even in young adults, probably more related to steroid use than anything else. Limb length discrepancy. So this is what happens when arthritis afflicts a joint that is growing. If it affects the knee, for instance, it can get longer. If it affects the jaw, it cannot grow as well. Micrognathia can be a problem. Many of these patients, especially before the biologic era, were candidates for joint replacement by the time that they became young adults. Fortunately, that's happening much less and less because we're doing a better job of treating them. And then, I think it's worth spending just one slide on uveitis. So as a pediatric rheumatologist, we care a lot about uveitis. This type of uveitis is called chronic anterior uveitis. It sort of presents insidiously. There's no evidence of inflammation in the eye, and there's no pain. So in children that can't really describe what they're seeing, it goes silent. So untreated, this type of uveitis can lead to blindness. And you know, I can tell you that I have several patients where their uveitis went undetected and they're almost blind. And this is very different than the acute anterior uveitis that you see with HLA-B27 related diseases when it's, you know, a painful red eye. So it's very important to screen. Uncontrolled, you know, it can lead to vision loss. But the good thing about it is that it typically happens in the very young children, and it typically happens within 4 to 7 years of diagnosis. So you notice these are the rate of uveitis among patients of different age groups. It levels off. So if your patient never had uveitis, they will not develop uveitis as adults. So you can be sure, you know, ask them, have you ever had uveitis? No, I never did. Then you're okay. If they have, then certainly sending them to an ophthalmologist is important. Step number 4, assess for chronic pain syndromes and fibromyalgia. Very important. So my patient, she had a pain score of 9 out of 10. Pain was all over. She had multiple myofascial tender points. You know, I plotted her pain scores from 0 to 10 over the period of a few years, and it was all over the place. But then when you plot her disease activity, for instance, by measuring the CRP, you could really not correlate the two, right? So the one point of time that I thought she had active arthritis, actually her pain wasn't so bad. So what do you guys think could be explaining her pain? Probably something else, maybe fibromyalgia. So it's interesting that when you assess adults with JIA, they have more body pain than otherwise healthy controls. This is really a great quote from the American College of Rheumatology. Pain in adults with JIA may be complex. I love it. And the question is why? Why is it so complex? So here's the question. What are common causes of pain in adults with JIA? And please select all that apply. Let's see how you guys are doing. And the truth is that all of these can cause pain in adults, all right? So these are the things that should be screened for when you're seeing your patients. So the last step is assess for depression, anxiety, and psychosocial issues. And my patient was no different than most adults with JIA. She's had depression, anxiety, PTSD, difficulties maintaining a steady job. She lived at home with her father still, even though she was age 24. And it's interesting that adults with JIA are less likely to be employed. So their educational status, they're just as educated as otherwise healthy adults. Sometimes studies have shown that they're more educated, but you know, there's a large proportion of patients that are unemployed. And what are the long-term outcomes of JIA? You know, studies have shown that there's higher rates of miscarriage, poorer body image, fewer are in stable relationships, they maybe have sexual problems because of disease. Fortunately, there's a lot of studies that are currently undergoing to better understand and optimize the management of kids with JIA. I'm part of the Childhood Arthritis and Rheumatology Research Alliance, and the whole point is it's a prospective registry. We want to collect 10,000 patients and follow them for 10 years. We've already reached our enrollment goal, and now we're following them over time. So again, what are the steps for successful transition? Certainly the most important, make the transition, figure out where they came from, what's their underlying disease category, think about active versus chronic damage, assess for chronic pain syndromes and depression. Here's some useful resources. Thank you very much for your attention.
Right. John, we have a bunch of questions. Sorry. Oh, yeah, we have time for a few questions. Sorry. Good jump. I give him a 6. I have to get my, A few questions about TMJ. How do you manage TMJ? And so one would be TMJ, I guess, pain and issues. And what about the kids with micrognathia? What should the adult rheumatologist be thinking about there?
Wow, complex question. So fortunately, the American College of Rheumatology just came out with guidelines about how to manage TMJ. I guess the bottom line is screen for it. As a pediatric rheumatologist, this is a joint that we often check for. I remember as a fellow, we had to measure intra-incisor distance and have to see whether the jaw is symmetric. And one of my attendings would get on my case if I ever didn't examine the jaw. So the most important thing is to try to detect it and prevent it from happening. At Children's, we refer to OMFS very early. We get MRIs if there's a question whether or not the jaw has been affected. If it's been affected, certainly we do more aggressive treatment like TNF inhibitors. And if there's been damage already, then the point would be to work with our OMFS. Sometimes they need jaw reconstruction surgery as adults.
OMFS means?
Oral maxillofacial surgery.
Just to be sure. Do you have a preferred drug for uveitis?
Yeah, so I'm not an ophthalmologist, but drugs that have been shown to be useful is certainly methotrexate and then TNF inhibitors like adalimumab.
What's the ideal age that the transition process should start?
Should start, as teenage, 12 years old or 13 years old, the pediatric rheumatologist should really be encouraging their patients to, answer questions. It's so frustrating when you get into a room, the child is 17, and you ask the child, how are you feeling? And mom answers for them, right? That should not happen. So already as children, they should learn to communicate directly with their doctors and take care of their medicines and speak with their doctors about what medications they're taking and how they're feeling. There's questions about when should they actually transition to adult medicine. That depends a lot on your institution, on their insurance companies. At Children's, we actually hold on to them until about after college, because college is, things are up in the air, and they may go to college in Wisconsin and then, come back to Boston afterwards. So we hold on to them, and once, they've finished college, we transition them. But I realize that in other places, sort of age 18 is when the transition happens. So those kids need to be even more prepared to do that process.
The kids who come to us who have not previously had uveitis, now they're adult JIAs, and we're going to manage them, should we be sending them to ophthalmology as you have?
Yeah, so I presented some data that if they haven't had uveitis, after 5 or 7 years of their JIA, it is very unlikely that they will develop uveitis as adults. So I typically do not send them regularly.
Is there any special considerations for those kids who have hypermobility who end up in our clinics, and how we should be managing those?
Hypermobility is a whole different beast. Hopefully we'll get a chance to learn more about, these patients are at increased risk of developing chronic pain syndromes, migraines, POTS, right, IBS. So it's a whole different talk. Yeah.
Agreed. Yeah.
I will defer.
Someone online said, some of my adult patients need parenting. As one who deals with kids and parenting, does that translate at all to your adult practice? Do you think you're better at coaching and parenting your adult patients, or what skills could you take forward?
Yeah, absolutely. So I think, one of the benefits of being sort of dual certified and seeing the experience in Children's is sort of the ability to work with families and to sort of meet them where they are. And I certainly carry that forward. Often in my young adults, I'm treating them a lot, parenting them and treating them as children because they haven't yet developed the skills to sort of self-manage their care. And so it's an educational process, every visit.
Yes, for all of us. So, John, thanks so much. This is great.
Thanks.